This is a panel on health economics. According to the program, it began at 2 o'clock. Let the record show that it's now 2:10. I don't know where those missing 10 minutes are supposed to go, but you'll advise me, Mark and John.
We'll have a 20-minute break after this session.
It'll be a 10-minute break. Anyway, some of you may be wondering why a panel on health economics at a session in tribute to Kenneth Arrow. You know that he spent very little of his career on health economics. And indeed, we wouldn't be here today if it weren't for one article that Kenneth wrote that has already been referred to. And that article is the sole reason why we are here. And you'll hear a little more about that article in a moment. Let me say that prior to Arrow, health economics was a very remote and dusty corner of our discipline. There were very few courses given in health economics, and maybe even fewer were taken. There were very few PhD theses written in health economics. And yet somehow, when he came along with this article, things changed, and they changed in a very great way. Earlier this year, there was a conference in Boston on an international conference of health economics, and the registration was over 2,000. Now, of course, it was the growth of healthcare expenditures that explains much of the change, and that's certainly true. But in terms of academia, in terms of academic research, it was Arrow's article that got the ball rolling. And Mark Pauly gave a very perceptive and succinct analysis of the success of that article. He said that Arrow made health economics respectable, and he also made it interesting. Hollywood also offers some perspective on this, because there was a demands team of Fred Astaire and Ginger Rogers. Familiar to most of you? They were enormously successful, and Hollywood explained it that way, that Fred gave Ginger class, and Ginger made Fred sexy. I would say that Arrow's article did both for health economics. I give you an impression that it was the only thing. No, there were other people helping along the way. One that I would mention, saw him here today. In 1982, Joe Newhouse started a journal of health economics, and he was the editor of that journal in a distinguished way for 30 years. And I would say that that helped keep the ball rolling, just as Kenneth's article got the ball rolling in the first place. I'll just read to you two little passages from the article so you can get a flavor of what it said and where we're going today with our discussion. In the opening paragraph, this is in the opening paragraph of the article, Arrow wrote with dazzling accuracy and extremely succinctly as well. The special economic problems of medical care can be explained as adaptations to the existence of uncertainty, you heard about that, in the incidence of disease and in the efficacy of treatment. Much of the rest of the article explains and explores the implications of this observation, and Amy Finkelstein of MIT will push it further along, reporting on some of her work about moral hazard. A second major theme of the article follows a discussion of inefficiency in medical care. Arrow wrote, "When the market fails to achieve an optimal state, when doesn't it?" Arrow said, "The market, society will recognize the gap, and then non-market social institutions will arise." And Alan Garber, who is a physician as well as an economist, will enlighten us a bit about those social institutions. Final panelist is Angus Deaton from Princeton. And Angus was struck by the fact, as I have been over the years, that Arrow in this article explicitly excluded any consideration of health. The article was only about medical care. And Angus will pick up the ball at that point and talk a little bit about health. Thank you very much. Yes.
Thanks. I'm delighted to be here, and thanks to Vic for reading a bit from that article. I was also tempted to do that. In fact, I could probably better fill my 10 minutes just reading from that article. It's the rare economics paper that you want to give a poetry reading on. It's rare to have an economics paper that you want to reread, or read, let alone reread. But Ken Arrow's 1963 article, Uncertainty and the Welfare Economics of Medical Care, makes that cut. And ever since we started teaching a graduate health economics course at MIT, we've urged our students to read it at the beginning of the semester and again at the end, telling them there are many, many dissertations still buried in those pages. And I've learned sometimes I should take my own advice to my students, so I've also started rereading it at least once a year. And I'm really struck every time I do by how much it has anticipated essentially all of the topics in modern health economics. And then I quickly realize, much to my embarrassment, that I've committed the cardinal empirical sin of having the causality backwards. Ken Arrow's article did not so much anticipate as instigate the subsequent research agenda. One aspect of that influence that's particularly striking to me is that although it is a theoretical contribution, the paper has inspired an enormous amount of follow-on empirical work. Indeed, one of the intellectual attractions for me of working in the field of health economics is the often close dialogue between the theory and the empirics. I suspect that a lot of this is due to early actual dialogues between the giants who founded the field, people like Ken Arrow on the theoretical side and Vic Fuchs on the empirical side. I could talk at length about the many rich strands of empirical work that have, over the years, grown out of specific particular observations in Arrow's incredible article. But I understand that I only have 10 minutes, and even I can't talk nearly that fast. So instead, I thought I'd talk briefly about just one of the many research areas sparked by that article, the topic of moral hazard in health insurance. Arrow defines moral hazard in health insurance as, quote, medical insurance increases the demand for medical care, close quote. This idea has spawned an enormous empirical literature examining whether and how health insurance affects healthcare use and healthcare spending. The first empirical question this literature has had to grapple with is whether moral hazard in health insurance even exists. Health insurance, by construction, lowers the price individuals pay for their medical care. First-year economics teaches us that demand curves tend to slope down, so that when we make something cheaper, people tend to buy more of it. So the answer may seem obvious, and indeed, it appears from reading his article that it was obvious to Ken Arrow. Not so much necessarily to the rest of the health economics field. In discussions about healthcare, there are at least two other views that are less sure. One view holds that healthcare cannot be analyzed like any other good. Demand for healthcare in this view is determined by quote-unquote needs, not by economic factors, or as we as economists might put it, the demand for healthcare is completely inelastic with respect to the price. Malcolm Gladwell has expressed this view forcefully in a 2005 New Yorker article tellingly entitled, quote, "The Moral Hazard Myth," expounding his central premise that the myth of moral hazard in health insurance is a singularly American obsession that has created our singular lack of universal coverage. He writes, quote, "The moral hazard argument makes sense only if we consume healthcare in the same way that we consume other goods. And to some, this assumption is plainly absurd. We go to the doctor grudgingly only because we're sick," close quote. There's also a second view heard a lot in policy circles, according to which the demand for healthcare, in fact, is upward sloping. One version of this conjecture is that health insurance will improve people's health by increasing timely and effective medical care, such as preventive care or better management of chronic conditions, and that this improved health will in turn reduce healthcare spending. Another conjecture is that insurance will get uninsured individuals out of expensive emergency rooms where they are required by federal law to be treated and into less expensive primary care. Indeed, this idea that insuring the uninsured will reduce expensive and presumably unnecessary or inefficient health care has been a leitmotif of advocates of expanding health insurance coverage in the United States. According to this view, we don't face any hard trade-offs. We can expand coverage and lower healthcare spending at the same time. So thus we have three widely circulated competing claims. Ken Arrow claims that health insurance increases healthcare spending. Many policy advocates claim that health insurance decreases healthcare spending. And Malcolm Gladwell claims that health insurance does not change healthcare spending. Empirical research on this theoretical question has allowed us to answer this question and to answer it in Ken Arrow's favor. Results from two randomized evaluations, the Rand health insurance experiment that Joe Newhouse led in the 1970s, and the Oregon health insurance experiment that Kate Baker and I led more recently, both show clearly that health insurance increases healthcare spending across the board, including those emergency room visits. Countless quasi-experimental studies have also found that health insurance increases healthcare spending. Ken Arrow, not surprisingly, was right. The empirical literature on moral hazard has progressed, thankfully, beyond merely confirming that Ken Arrow's theoretical conjecture was correct, even if sometimes the policy discourse has not. Much of the work now is on understanding the nature and the magnitude of the moral hazard response to health insurance that he first discussed, and using these estimates to empirically forecast what spending would be under counterfactual plans or healthcare policies that are being proposed, such as high-deductible health insurance plans, expanding or contracting Medicaid depending on which day it is, or closing the famous donut hole in the Medicare Part D plans. I should note in closing one concern with this vast empirical literature on the moral hazard effects of health insurance. The literature has focused on the responsiveness of consumer demand for healthcare to the price she has to pay on it, conditional on her underlying health status. In that sense, my field's use of the term moral hazard is a bit of an abuse of the traditional hidden action meaning of the term moral hazard. The action in this case, i.e. the individual's healthcare utilization, is in fact not hidden. It's observed and it's contractible. The asymmetric information problem may be more naturally described as a problem of hidden information regarding the individual's underlying health status and healthcare needs. Fortunately, when one's conscience is troubled by potential abuse of terminology in one's field, one can always follow the advice I began with: reread Ken Arrow's 1963 article. And indeed, in his discussion of moral hazard, he, not surprisingly, is thinking of an example that is completely consistent with the hidden action meaning of the term, even if we subsequently lost sight of it. Specifically, he notes, quote, Insurance removes the incentive on the part of individuals, patients, and physicians to shop around for better prices for hospitalization or surgical care. For a long time, it seems we lost sight of this insight, and most empirical work, as I said, focused on quantities, not on prices. How did healthcare use respond to health insurance? Arrow's original example of moral hazard, however, involved the reduction in incentives to exert effort to search for lower prices for the same care. In other words, it was about how healthcare prices, rather than healthcare quantities, would respond to health insurance coverage. In just the last few years, the empirical health economics literature has finally returned to this insight of Ken Arrow's and begun to find the data to document the extraordinary price dispersion within markets across healthcare providers and begun to examine its sources. Indeed, just this year, a paper appeared in the Quarterly Journal of Economics exploring Arrow's original idea that one way health insurance may affect healthcare spending is by affecting consumer incentives to price shop. In this paper, Amitabh Chandra at Harvard, together with Zarek Brock-Goldberg, Ben Handel, and John Kolstad at Berkeley, looked at whether and how a high-deductible health insurance plan affected consumer price shopping for specific medical procedures. We have clearly not exhausted the rich veins of empirical inquiry suggested over a half-century ago by Ken Arrow's seminal paper, even on the single topic of moral hazard in health insurance, which occupies about a quarter of a page in that article, not to mention the myriad other questions about healthcare markets that he raises in that paper. It's a delight and it's a privilege to do empirical work in a field with such a rich and seemingly bottomless set of theoretical insights to draw on, and I can't wait to see what the next half-century will bring.
I just want to add my thanks to the organizers of today's event. It's a huge honor to me to be here. I have to say that I was delighted that Vic decided to frame this session around this paper of Ken's. I first encountered the paper in an edited volume of Ken's called Essays in the Theory of Risk-Bearing. Can I ask how many people in the room have a copy of that book? Hold on to it. I just checked on Amazon this morning. It's selling for $810 a copy. So there's a lot of classics in that book. This may not be the particular essay that is responsible for its high valuation on Amazon. But as Amy has said and as Vic has said, it's an extraordinary article that opened up a field. And I want to follow up on the quote that Vic had from Ken's article about the role of non-market institutions to address the market failures in healthcare. And actually, my understanding, I may look old, but I'm not old enough to have been around when or to have been in college yet, when the article came out, but it was not free of controversy. And those of you who read the article will know that he attacked some of the prevalent theories and naming the people who propounded some of these theories about why healthcare markets work the way they did. And his point in the paper was that these non-market institutions actually might have welfare-enhancing features that markets can't fully address, especially because of the inherent information asymmetries that characterize medical care. And he focused very heavily on physicians, but he was talking about other institutions as well. And he also cited two kinds of information that I don't think were common for economists to look at the time. One of them was the work of a sociologist, Talcott Parsons, who many of you I'm sure are familiar with, who pointed out the importance of norms in professional behavior. And of course, the applicability here is physician knows much more about you, your health condition, knows much more about likely response to treatment, maybe knows more about how much he, and at the time it would have probably been a he, will earn from recommending a particular course of therapy, and so on. And Parsons had talked about the role of professional norms in basically preventing abuse of this asymmetric information by physicians. The second important piece of sort of outside information came from something called the Flexner Report. The Flexner Report was published in 1910, and at that time, medical schools in the US were predominantly profit-making, proprietary institutions that did not train doctors, shall we say, in a particularly scientific approach to medical care. And Flexner was commissioned to go around and survey medical schools and revealed the dire state of medical education in most institutions around the country. Most medical schools, by the way, were not affiliated with universities at the time, and he held up Johns Hopkins in particular as a model. When Ken read this, he recognized that there might be a very important role for some kind of certification or professional standards to essentially protect patients from unscrupulous and poorly trained physicians. So he felt very strongly, based on having read this other material, that there was a big role for professional norms and other kinds of non-market institutions. So one of the questions you might ask is, well, what exactly is a non-market institution? What are these alternatives to market institutions? Do they have an important role to play? Did they then? And more importantly, do they today? So much has changed then, since then, particularly when you think about the availability of information. And is it plausible that they enhance welfare? Now, here I have to disclose a conflict of interest. I am a licensed physician. I'm a member of the Guild. And so maybe I'm not totally objective about it, but you can be forewarned. But the question that, say, Ruben Kessel, one of Arrow's critics, raised was, are these non-market institutions like medical licensure, which is a government activity, or specialty certification, which is usually controlled by specialty organizations, are they not merely a means for physicians to raise their incomes by basically restricting supply? Couldn't you just inform people about whether you have these kinds of qualifications rather than restricting who can practice by the means of licensure? So that was one of the big questions at the time. And Ken's response implicitly in the article was that, in fact, their behavior is different if they're held together by these kinds of professional norms. So what's happened since then? Think about the information asymmetry. There's a factoid that's been around. You've all heard that the most common reason to do a web search is to look for health information or medical care information. I actually looked on Google Trends recently, and it's not way up there. So there's different measures you can use. But suffice it to say that I would suspect that everybody in this room has at one time or another searched on the web for health information. The tools are widely available. At the time that Ken wrote his article, if you as a patient wanted to get information about the disease that you have that's comparable to what doctors have about it, you would go to a well-equipped medical library, not your public library, look up in these massive volumes called Index Medicus by the subject, what journal articles have been published, and then go pull the articles off the shelves in a library. Very, very difficult for someone who is not a professional to access the information. Today, of course, all of that information is available on the web, and a huge fraction of it is not under restricted access of any kind. In other words, it's available for free. So some of the information asymmetry is being addressed. Amy spoke about these, some of the studies about price sensitivity on the part of patients. So today, there are companies that actually specialize in making, I should say, cost information available to patients. And just to be clear, I mean how much you as a patient will have to pay to receive a service from a particular provider. So the information is much more widely available now. So is this still true? So here I'm going to deviate a little bit from real empirical work to talk a little about my anecdotal experience as a physician who's in an in an academic position, and I have my own metric of how many calls I get from colleagues in the university, both when I was at Stanford and now at Harvard, asking who's the best doctor or how should I be treated. So my hypothesis would be if this information is so widely available, the volume of calls would go down. It's gone up. Okay, now I haven't done the full regression, I haven't adjusted for the aging of my colleagues, but suffice it to say, I would suspect none of you with an important health condition would dispense with getting some kind of personal advice. So on that rather thin bit of empirical evidence, I would argue that in fact there has been much less change in the availability of the kinds of information that patients need at the time that they actually experience the health condition. So there's also been changes in how we deliver care. So when you think about the information asymmetry, and in particular, the moral hazard problem that Amy talked about, the whole point of capitation is to directly address this issue. In other words, the healthcare provider is not incentivized to provide more services. Yet in fact, by the measure of what's happened to healthcare costs, this has barely made a dent, and in fact, the increase in capitation, the use of capitation that came about in the 90s was not sustained. So that has not been a solution. So are these non-market approaches welfare enhancing? That's a very, very complicated problem, in part because we don't have great data to answer that. But one of the few gaps in Ken's article is that he only looked at the United States. And had he looked at other nations, he would have seen that there are other kinds of non-market organizations and kinds of government intervention that clearly have had effects on restraining health expenditures, and I believe would have strengthened his argument considerably. Let me close by saying that he addressed many other issues that are not solely about information asymmetry. He mentioned in passing, for example, the possibility of increasing returns to scale. And for many of us, one of the striking changes in healthcare delivery over recent decades has been the recognition that there really are increasing returns to scale, that market concentration, especially in provision markets, healthcare provision markets at the hospital level, may be inevitable, and it's actually enhanced by the role of information technology rather than being diminished by IT. And you can see this in the mergers of health systems and the massive expenditures for IT that are integrated into healthcare delivery. Ken raised this as an issue. He didn't explore it in depth. But again, this is a case where non-market institutions, for all the usual reasons, may be necessary to deal with the resulting monopoly issues that occur. So did this perspective contribute to our understanding? As somebody who has taught from this article for virtually my entire career as a faculty member, I would say resoundingly yes. And I have to say, even teaching freshmen at Harvard who are just taking their first economics courses, I'm just astounded at how it continues to have the power to inspire and to enable students to understand how economics can be an extraordinarily powerful tool for understanding the world. Thank you.
It's a very great honor to be here today. And I too would like to thank the organizers, and especially my friend, Vic Fuchs, for inviting me to be here today to talk about health. I met Ken right at the beginning of my career in 1969, in the same place that Jim Merlis did, when he would come to Cambridge to work with Frank Hahn. Unlike Ken, Frank was rather hostile to empiricists, and I missed the opportunity to get to know Ken, something that I've regretted ever since. To preface my remarks, I note that Ken was adept at something that is rather uncommon today, which is the building of bridges between theory and applications, including forging tools that empiricists could use. A famous example, which Larry Lau already talked about, is the 1961 so-called SMAC paper with Chenery, Minhas, and Samuelson that introduced the CES production function, one of the most productive and long-lived tools for making sense of data in a theoretically coherent ways. Sorry, I seem to have spreaded a cold at an inopportune time. More explicitly about health, Ken wrote an important but actually never published paper in 1975 on what today would be called the external validity of randomized controlled trials. Once again, it is about how to use theory to interpret empirical evidence and to extend it in a way that brings it closer to what we need. One of the themes of everything we've heard today is the relevance now of so much that Ken did. The importance of the issues on which he worked has kept his work alive, and this is a fine example. Indeed, the contemporary literature is much concerned about how and where to use the results from randomized trials, including how to transport them to a new context from the original one. The 1975 paper is about the RAND health experiment and proposes a solution to a problem that plagued experiments then and now, that what you get, although clearly useful and informative, is not exactly what you want. In this case, the problem, which again is a common one, is the experiment could only be run for a period of time that is short compared with what would happen if the policy being tested were actually adopted, in which case it would presumably last indefinitely. Ken sets up the health experiment as a two-period model in which the price of medical care is lowered in the first period only, and shows how to derive what it is we want, which is the response in the first period if prices had been lowered by the same proportion in both periods, the experimental period and the period afterwards. The magnitude that we want, I'll call S, which is the compensated price derivative of medical care in period 1 in the face of identical increases in P1, the price in the experimental period, and P2, the price in the post-experimental period. So this amount S is the sum of S11 and S12, where S11 is the compensated derivative with respect in period 1 with respect to period 1's price, and S12 is the compensated price derivative of healthcare in period 1 with respect to the price in period 2. You want the sum of those two things. The trial gives you S11, which you can observe directly from the randomized controlled trial. But what Ken noticed was that if we have post-trial data on medical services for both the treatments and controls, we can infer S21, which is the effect of the price in the experiment on the post-experimental expenditure. So by Slutsky symmetry, S12 and S21 are the same. So from S21, which you can observe, you can get S12, you can add it to S11, and lo and behold, you've got the long-run price elasticity S, which is what you want. He also investigates an alternative solution, which makes a different assumption that preferences are intertemporally additive, in which case the long-run elasticity can be obtained from knowledge of the income elasticity of post-experimental healthcare, which is relatively straightforward to obtain from non-experimental data. Now, to me, this seems exactly the right way to use and to extend experimental results. That such methods are little used today is something of a puzzle to me, perhaps explicable in part by increased skepticism by applied people and by experimentalists about the use of theory, particularly perhaps price theory. An important early statement in Ken's 1963 AER paper is a declaration of scope that Vic already referred to. Let me quote. It should be noted that the subject is the medical care industry, not health. The causal factors in health are many, and the provision of medical care is only one, end quotes. As often, Ken's wisdom was not always noted. And because this 1963 paper is so important and so foundational to health economics as a subject, health economics subsequently became synonymous with the industrial organization of the healthcare sector. And in spite of Ken's caution, this bias against health per se took many years to overcome. The causes of differences in mortality between countries or between places in the same country, like across states in the United States, are still not well understood. And there are still long-running controversies about the role, if any, of medical care in the astonishing increases in life expectancy in rich countries in the 20th century, not to mention the slowing down of that increase, and in the United States in the last few years, reversals in the 21st century. We coordinated very carefully within panels, but we didn't coordinate across panels. So I wanted to tell the Artemisinin story again, and I have a slightly different take on it, so I'm going to go ahead and do that. It's a good story, and it's worth hearing twice. So Ken chaired this panel in Institute of Medicine, as it was then called, panel on malaria prevention, and more specifically on what to do about malaria's increasing resistance to chloroquine. This is another major area in which healthcare organization is not the central issue. In fact, healthcare in most very poor countries has very little to do, health in most poor countries clearly has very little to do with healthcare. Ken described the panel as one of the most exciting experiences of my life. One of his co-panelists, Sir Richard Peto, the distinguished British epidemiologist who thought that economic aspects of malaria control would be uninteresting, one suspects he thought all of economics would be uninteresting, said afterwards that it was one of the most interesting committees he had ever been involved with, and noticed the potential of the committee's recommendations to save enormous numbers of lives. Resistance is almost perfectly suited to Ken's lifelong understanding of both the power of markets and of their failures, and of the possibility that government action can do better. Currently, about 1 million children a year die from malaria, yet the disease is relatively cured in a few days by anti-malarial drugs. Quinine is the oldest and most famous of those. Chloroquine was one of the following drugs, and that used to be effective and in a few places still is. It is produced mainly in Asia and is cheap enough and widely distributed so that even the poorest people in Africa had access. The market worked, but the externalities in terms of resistance to chloroquine have destroyed the effectiveness of the drug in Asia, in East Africa, and increasingly in West Africa. The latest generation of antimalarial drugs is artemisinin, also known as sweet wormwood, discovered by 2015 Nobel laureate Tu Youyou in China. She was sent by Chairman Mao to search ancient manuscripts for long-forgotten cures. In this case, and it appears in this case only, with spectacular success, attempts to find other long-forgotten cures have not been similarly successful. Artemisinin is effective today, but it will not last long. And the aim of Ken's committee was to evolve a strategy that would buy time by encouraging the use of artemisinin combination therapy, ACT, that would greatly slow the development of resistance. Essentially, the mutant parasites that are resistant to artemisinin are eliminated by the other drugs in the combination. The panel's report is a veritable compendium of market failures, including the failure of the market itself to value the lives of poor people, as Ken put it, in any direct way, as well as non-convexities in the development of new drugs, which is why new antimalarial drugs appear so infrequently. And externalities, the global externality of resistance itself, the local externality that comes from people infecting other people near them, and the international externality from one country not using ACT, exporting resistance to neighboring countries. Ken's proposed solution is a global subsidy to be paid to producers at a cost of about $1 billion a year to save about 1 million lives, or about $100 per disability-adjusted life year. As Ken notes, this is, quotes, in fact so low that there is hardly any point in comparing it with alternative methods of saving lives. I have a somewhat more jaundiced view than Eitan's about the success of this. There has indeed been a massive decrease in infant mortality through malaria. I'm not sure how much of it is due to ACT or how effective they've been in eliminating monotherapies around the world. There's also a real question of the extent to which this approach can work at all, as to how much time you can actually buy by blocking off resistance for a while. But all of this brings me to my final point, which is that so many of the great insights of economics, including so many of Arrow's, have not become part of our common understanding. Common understanding in this room, I'm talking about much broader common understanding in the population, let alone part of policy, even in rich and relatively well-educated countries like the United States. Much of Arrow's work, including the health work, is about how the market does not work, and yet so much of our public life is infected by a market fundamentalism that brooks no analysis. Sad, to quote one of the perpetrators. At the end of the 1963 paper, Arrow writes, and this is the last quote, "It is the general social consensus, clearly, that the laissez-faire solution for medicine is intolerable. I only wish it were so clear." Thank you.
Thank you. I'd like to throw a question at each of our panelists, starting with Amy Finkelstein. Amy, many OECD countries have more complete insurance coverage than the United States does. Those same countries spend about 12% of the GDP on healthcare, and we spend 18%. Would you please comment and maybe reconcile that with some of your earlier remarks?
Sure. If you can tell me how to turn on the microphone.
It's on.
Oh, it's on. Okay. Yeah, that's a great question. And actually, I originally had included a section on exactly something I think related to this in my remarks, and then I decided I was short on time, so I'm glad for the opportunity. I think one way to think about it is that the work that I was describing on consumer cost sharing in healthcare, how much the individual needs to pay out of pocket for healthcare, is motivated in large part, and I think it shows in Arrow's original paper, by a sort of fundamental welfare trade-off in insurance design between, the ideal first best insurance would provide full coverage, yet that has perverse incentive properties. That's the moral hazard problem. And so we need to know how big is that incentive effect, that moral hazard response, in order to figure out optimal insurance design. The work, however, and this goes to Vic's point, has been used a lot in academia and policy to think about implications for aggregate healthcare spending. And I think on this, Vic is not surprisingly exactly right, that if we want to understand not the the optimal design of insurance problem that the original moral hazard problem was related to that I described, but actually massive differences in healthcare spending across areas within the United States or across countries, we need to look not so much at consumer incentives, but at provider incentives. So Alan, for example, mentioned capitation as one example. There are many forms of the design of institutions and organizations in medical care. And I think the way to see this most clearly is the fact that I think many people in this room have heard that, that healthcare spending is extremely right skewed. Some large share of healthcare spending is accounted for by a very few number of people. Those people have obviously long since spent past their deductibles and co-payments. And so what's really driving healthcare spending is not consumer cost sharings, but the organization of the supply side of the market.
Thank you. Alan, you know that there are hundreds of specialty boards and subspecialty boards in the United States. And I wonder if these were the kinds of social institutions that Kenneth Arrow had in mind. I wonder if you were looking at them now and had to make a hard judgment, are they fulfilling his vision that they would bring medical care into better welfare alignment, or as some people think, they actually have the reverse effect? Do you have any judgment on that?
Is this being recorded?
Yes.
Vic, okay, I'll give an appropriate answer. As you say, there are hundreds of specialty societies, and that means it's impossible to generalize. But I would guess that pretty much all of them provide some elements of what Ken was looking for when he described the role of these non-market institutions, and that does have to do with a certain amount of quality assurance. What's interesting to see happen over time is that you may refer to some of the guild-like properties of these specialty societies in restricting supply. Surgical specialties strictly control the number of residency programs in their areas. But increasingly, they are being called upon to provide more meaningful assurance that the quality of care that their members provide is high. And some of them actually have gone to great lengths to do so. And it may be that they do that under external duress. They may be under pressure from government agencies and other sources to do so. But they do continue to provide important services. To give you an example, when a new technology called implantable cardiac defibrillators became available, they were clearly effective for a small subset of people who were potential candidates to receive them. And the question is whether they were actually providing benefit when used in the community at much higher rates. And so the Heart Rhythm Society, one of these specialty societies, created a registry so that it would be possible to actually do studies to find out whether they were providing benefits. And that's the sort of thing you're seeing increasingly. So I would argue that it's a mixed picture, but Ken was not being naive. And I have to say, Ken was never naive. It would always be a mistake to think that of him, and his somewhat rosy picture was not completely off.
Thank you. I'll enter a little dissent there on yours. Not the remark about Ken, but about these things. It seems to me, on the basis of work I've done, not comprehensive but limited, that we have more specialists than we need in many areas and many specialties, that the prices that they charge are higher than one could reasonably think of as a competitive price, and that we would be better off, and that their workloads are below what many of them are capable of. So you put all those things together, I think that we have to make a different judgment about them, although you might say, well, if you do away with them, what will you have left? Chaos, and that's a possible response. Angus, you and I agree that there's relatively little work done on the economics of health as opposed to the economics of medical care. I think we also agree that it might be desirable if there was some shift in emphasis and more attention to health. Do you have any ideas about how economists could get into that business?
Oh, I think that's hard, and it would be wonderful if Ken had written the other paper, as it were, you know, which is how do you think about health. One of the things that I've been worrying about most recently is that I think there's really serious concerns now that, you know, we may have to study medical care to study health, but in the opposite direction. That actually, I think there's increasing evidence that medical care, in some of its dimensions, is actually undermining American health in rather serious ways. So, you know, it's a sort of, Ken had said that medical care is only part of health, but it may be that parts of medical care, it's worse than that. They're going the opposite direction. I don't think there's any clearer example than that, than the current opioid crisis, where, for example, this is a CDC number, not my number, that there's currently enough opioids being prescribed for every adult in the United States to have a month-long supply. Those opioids are essentially heroin with an FDA label on them, and in some cases they're actually more effective at addicting people than heroin is. These are actually part of the reduction in life expectancy in the United States over the last 2 years for the whole population, and for whites, non-Hispanics, for a somewhat longer period. At the same time, the Sackler family that owns Purdue Pharmaceutical, which is a family-held firm, and whose names appear on our public buildings all over the United States, including the National Academy of Sciences. That family, up until the middle of last summer, 2016, according to the Los Angeles Times, had made $31 billion in profits out of selling one of those drugs, which is OxyContin. And that drug is incredibly expensive, and it's reducing US life expectancy, and it's addicting tens of thousands of people and undermining the labor market. I mean, the other half of this is something that Vic has written about very eloquently, that, and just to come back to what Alan just said too, I think it might be that Ken was right then, and he's not right now. I mean, I think there's been a sharp deterioration in professional standards and standards of behavior over the last 40 or 50 years, that people would not do things for money that now they will do for money. At the same time, the healthcare sector has been relentlessly consolidating, raising prices, practicing monopsony. There's been a so-called shortage of nurses for about 25 years. How can you have a shortage of nurses for 25 years without serious failure of competition? Enormous amount of rent seeking by hospitals and by pharmaceutical companies. And all of this is ultimately a big reason why wages have stagnated for the past 50 years. I think that stagnation of wages got a lot to do with not only opioids, but rising suicides and rising deaths from cirrhosis, and perhaps even from heart disease, which is now going up after being the major driver of mortality decrease for the last 50 years. So, I mean, we may have actually got ourselves into a place in this country, and Vic's figures, I think, are a few years out of date. It's about 18% of GDP. And if you compare that with 12, that 6% of GDP is $1 trillion a year. It's about $8,000 for every family in the United States. And that's sheer waste. I mean, or sheer waste as far as welfare is concerned. It's certainly earning very large salaries for some people.
Could I respond just a little bit to that? Yeah. So, Angus, I agree with many of your points, but I would just point out when we're talking about what Ken had claimed, he did not claim that these non-market institutions resolved the problem. He claimed that they would moderate it, and to say that things have gotten worse is not the same as saying that that these have been completely ineffective, right? So
we're on the same page. I just thought that just as in business, I mean, people didn't used to get paid $13 million a year. They got paid $100,000 a year. And there's been a just sense of letting everything, you know, there's been a decline in sort of the abstemious professional standards that people used to think. And I don't think doctors are special in this. I think we're all in it. You know, we used to be academics because we wanted to change the world. Now we're academics because we got paid a lot of money.
I think we'll close with a reminiscence. Goes back to the time when Alan Garber was a junior at college. Do you remember the year?
1970, depends on which year you count as my junior year, but I think 1975.
Anyway, I received a telephone call out of the blue in which he introduced himself as a junior at Harvard, majoring in economics, and he had just been accepted to the Stanford Medical School, and his problem was that he would like to defer the acceptance for a year so that he could finish up his graduate work in economics at Harvard. I was impressed by that, so I kept on listening. And I said, we can arrange the deferment at the medical school. He explained that he wanted to get a PhD in economics, and he wanted to be a physician as well. Well, when I heard that, I thought better discourage him a little bit. And I said, you know, if you want to be an economist, there are a lot of people around here who can teach you about health and healthcare and technology and so on. I don't think you need to go through all the MD stuff and so on. And if you want to be a physician and you want to do so with a thought about economics, there are also people who can train you in that regard too. It doesn't seem to me that getting a PhD and an MD was a good investment. And he closed the conversation by saying that for him, economics was consumption. Of course. Couldn't quarrel with that. Well, the final joke turned out to be on me because it turned out to be a very good investment to have both the degrees. Thank you all very much.